All right, let's jump right in. Picture this. You're in the final, most intense moment of your surgical training. It's the consultant oral exam, the viva. Everything you've worked for comes down to how you handle the next few minutes. Today, we're going to step into that very hot seat and break down a classic high-pressure trauma surgery case. So here's our game plan. We're going to follow the case just like in a real exam, starting right from the patient's arrival in the trauma bay. Then we'll walk through the critical decisions, the nitty-gritty of the surgery, and finish up with handling those tricky post-op complications. Let's get started. You walk into the exam room. The examiner gives you a slight nod, the clock starts, and they lay out the scene. The examiner leans forward. A 30-year-old male arrives by ambulance after a high-speed motor vehicle collision. His Glasgow Coma scale is 7. He's hypotensive at 80/50, and his heart rate is 130. Talk me through your primary survey. A good candidate doesn't panic. They immediately create structure. You'd say something like, my approach is guided by ATLS principles. You start with airway, making sure to protect the C-spine. Now, the key number here is that GCS of 7. That's a huge red flag. It means the patient can't protect their own airway and needs intubation right now. Then you move to breathing, checking the chest and circulation, which means getting big IV lines in, sending off blood, and starting resuscitation. A structured answer like this is exactly what examiners want to see. It shows you can think clearly under fire. Okay, the examiner's happy with that initial answer, but they're not going to make it easy. They immediately move to the next critical decision point, turning up the heat. So, the patient isn't getting better with fluids. The examiner asks, you suspect intra-abdominal bleeding. What is your next single diagnostic step? And you've got to pay attention to that word, single. They're testing your ability to prioritize when every second counts. The correct answer? It's the FAST scan, the focused assessment with sonography for trauma. Why? Because it's fast. You can do it right there at the bedside, and it doesn't involve cutting the patient. In a patient this unstable, a positive FAST scan means one thing, a one-way ticket to the operating room. Now, a truly excellent candidate would also mention the backup plan. If the FAST is iffy, you'd move to a diagnostic peritoneal lavage, or DPL. Mentioning that shows you're thinking 2 steps ahead. All right, so while you're getting ready to rush the patient to the OR, a call comes in from radiology with some critical new information. The head CT is back, and it's bad news, an acute subdural hematoma. The examiner zeroes in on this, testing pure, high-yield knowledge. What are the absolute indications for surgically evacuating an acute subdural hematoma, regardless of the patient's GCS? To nail this question, you need to have 3 numbers memorized cold. A great candidate would just rattle them off. The first absolute indication is a hematoma that's thicker than 10 millimeters. The second is a midline shift of more than 5 millimeters. And the third is any drop in the GCS of 2 points or more since the injury, or if the patient's pupils become fixed and dilated. You can feel the tension here, right? It's a race against time, with 2 different surgical teams needing to operate at the same time. Okay, the neurosurgeons are scrubbing in. The examiner pulls your focus back to the immediate problem, back to the abdomen. The examiner says, the FAST scan was positive. You're taking the patient to the operating room for an emergency laparotomy. Walk me through your initial operative approach. The perfect answer here is all about control. You describe making sure the OR is warm and the blood bank is ready. Then, a big midline incision from top to bottom. And the very first thing you do inside? Pack all 4 quadrants of the abdomen to get temporary control of the bleeding. But you know what a truly great candidate would add? They'd mention telling the anesthesiologist right before they open the belly, because releasing that pressure can make the blood pressure tank. It's a small detail, but it shows you're not just a surgeon, you're the leader of that whole trauma team. And here it is, the classic viva curveball. The examiner says, you've packed the abdomen, but you find a huge, nasty liver injury that is still bleeding everywhere. What is your next maneuver? The answer they're looking for is the Pringles maneuver. That's where you clamp the main blood supply going into the liver. But what's really cool about this is, it's not just a way to stop the bleeding. It's also a diagnostic test. If the bleeding stops when you apply the Pringle, you know the problem is the hepatic artery or portal vein. But if it keeps bleeding, the injury is deeper, probably involving the massive veins behind the liver. So this one simple move both buys you time and tells you where the problem is. The Pringle helps, but the patient is circling the drain. The examiner pushes you further. The patient is now cold, coagulopathic, and acidotic. What's your strategy? This is the lethal triad of trauma, a deadly downward spiral that is incredibly hard to stop. The correct answer here is one of the biggest paradigm shifts in modern trauma care. You pivot to damage control surgery. The goal isn't a beautiful, perfect repair anymore. The goal is to save the patient's life. That means you pack the liver, quickly control any other injuries, slap on a temporary abdominal closure, and get out. You rush the patient to the ICU to get them warm and correct their blood clotting. It's a huge strategic shift. You're saving the patient's physiology, not just their anatomy. So the patient has survived the initial onslaught. They're recovering in the ICU. The examiner shifts gears for the final phase of the viva. The examiner wraps it up with a classic high-yield question to see if you're thinking about the long game. What are the 3 most common complications you would anticipate after a severe liver injury, and how would you manage each one? A slam dunk answer here is just a clear, organized summary. First, an abscess, which you treat with IV antibiotics and a drain. Second, a pseudoaneurysm, basically a weakened spot in an artery that can blow out later. You'd manage that with angiographic embolization. And third, a bioleak or biloma. You start by draining it, but if it keeps leaking, you'll need to go in with a scope, do an ERCP, and place a stent. And just like that, the examiner says, excellent, and the viva is over. The candidate passed. What's so amazing about a simulation like this is how it really boils down the essence of trauma care. You start with a systematic approach, ATLS, to create order out of chaos. Then you have the wisdom to make a critical pivot to damage control when the patient's body is failing. And finally, you have the foresight to look down the road and handle the complications that are sure to come. This case is a perfect example of the chain of survival in trauma. Every link is important. But it makes you wonder, right? From the decision to intubate, to the fast scan, to the Pringles maneuver, what was the single most critical decision? While every step mattered, I would argue that the most pivotal moment was the decision to switch to damage control surgery. It's the moment you recognize you have to treat the patient's entire failing system, not just the one bleeding organ. That change in mindset, from being just a surgeon to being a resuscitator, is probably what made the difference between life and death.